Welcome guys. Today's lesson is about diaphragmatic hernia in newborns. A diaphragmatic hernia is defined as a congenital communication between the abdominal and the thoracic cavities with or without abdominal contents in the thorax. The defect might be as the esophageal hiatus, which is called hiatal hernia, at paraesophageal sites, might be retrosternal, and also posterolateral portion of the diaphragm, which is the most common type, and which is called Bokdalic type. In congenital diaphragmatic hernia, the Bokdalic hernia, which accounts for up to 90% of hernia seen, with 80 to 90% occurring on the left side. The Morgane hernia accounts for 2 to 6% of congenital diaphragmatic hernia. The size of the defect is highly variable, ranging from a small hole to complete agenesis of this area of the diaphragm. When we see pathology and etiology of congenital diaphragmatic hernia, although congenital diaphragmatic hernia is characterized by a structural diaphragmatic defect, a major limiting factor for survival is the associated pulmonary hypoplasia. Lung hypoplasia can be caused by the compression of the lung from the herniated abdominal contents, which impaired lung growth, and it's secondary, and in some cases it might be part of the malformation, and it might precede the development of the diaphragmatic defect. Pulmonary hypoplasia is characterized by a reduction in pulmonary mass and a number of bronchial divisions, respiratory bronchioles and alveoli. The pathology of pulmonary hypoplasia and the congenital diaphragmatic hernia includes abnormal septa in the terminal sepals, thickened alveolus, and thickened pulmonary arterioles. And the biochemical abnormalities include relative surfactant deficiency, increased glycogen in the alveolus, and the decreased levels of phosphatidylcholine, total DNA, and the lung total protein, and all of which contribute to limited gas exchange. When we see the epidemiology, the incidence of congenital diaphragmatic hernia is between 1 in 2,000 to 1 in 5,000 live births, and the females are affected twice as often as males. And the defects are more common in the left, which accounts for 85%, and they are occasionally bilateral, less than 5%. In the rest, around 10% is on the right side. And the pulmonary hypoplasia and the malrotation of the intestine are part of the lesion, not associated anomalies. Most cases of congenital diaphragmatic hernia are sporadic, but familial cases have been reported. Associated anomalies have been reported in up to 30% of cases, including CNS lesion, esophageal atresia, omphalocele, cardiovascular lesion, as a part of several chromosomal syndromes such as trisomy 21, 13, 18, Pallister-Killian syndrome, Turner syndrome, and others. When we see the diagnosis, in more than 50% of cases, congenital diaphragmatic hernia can be diagnosed on prenatal ultrasonography between 60 to 24 weeks of gestation. Ultrasound findings may include polyiramnios, chest mass, mediastinal shift, gastric bubble, or a liver in the thoracic cavity, and the fetal hair robes. After delivery, a chest radiograph is needed to confirm the diagnosis. And in some infants with anechogenous chest mass, further imaging is also required. This is a chest X-ray of a newborn with congenital diaphragmatic hernia. As you see on the image on the right side, a nasogastric tube is recoiled back to the thorax after entering the lower abdomen. This is due to the herniation of abdominal contents through the diaphragmatic defect into the chest. When we see the clinical presentation, respiratory distress is a cardinal sign in babies with congenital diaphragmatic hernia, and it may occur immediately after birth, or there might be a honeymoon period of up to 48 hours during which the baby is relatively stable. And early respiratory distress within 6 hours after birth is thought to be a poor prognostic sign. Respiratory distress is characterized clinically by tachypnea, grunting, use of accessory muscles, and cyanosis. Children with congenital diaphragmatic hernia might also have scaphoid abdomen and increased chest wall diameter. And also ball sound might also be heard in the chest with decreased breath sounds bilaterally. The point of maximal cardiac impulse might be displaced away from the side of the herniation if mediastinal shift has occurred. And a chest radiograph and the passage of nasal gastric tube are usually sufficient to confirm the diagnosis, as I have showed you above. A small group of infants with congenital diaphragmatic hernia presents beyond the neonatal period, and the patients with a delayed presentation might experience vomiting as a result of intestinal obstruction or mild respiratory symptoms. Occasionally, incarceration of the intestine precedes to the ischemia with sepsis and a shock. Unrecognized diaphragmatic hernia is rare, and it can cause sudden infant death syndrome in some infants and toddlers. And the group B streptococcal sepsis has been associated with a delayed onset of symptoms and congenital diaphragmatic hernia, often on the right side. Regarding treatment, the initial management include delivery at tertiary center with experience in the management of congenital diaphragmatic hernia is required to provide early and appropriate respiratory support. In the delivery room, infants with respiratory distress should be rapidly stabilized with endotracheal intubation. And a prolonged mask ventilation in the delivery room, which enlarges the stomach and small bowel and thus makes oxygenation more difficult, must be avoided, and a nasal or orogastric tube placement should be done immediately for decompression. A preductal arterial oxygen saturation value more than 85% should be the minimum goal, and volutrauma is a significant problem, so it should be avoided. Gentle ventilation with permissive hypercapnia reduces lung injury, need for ECMO, and mortality. Factors that contribute to pulmonary hypertension, such as hypoxia, acidosis, hypothermia, should be avoided. And routine use of nootrops is indicated in the presence of left ventricular dysfunction, and the child should be seen by cardiologist with echocardiograph. Babies with congenital diaphragmatic hernia might be surfactant deficient, as I have said above, and they might also need surfactant replacement therapy. Regarding surgical repair, most experts wait at least 48 hours after stabilization and the resolution of the pulmonary hypertension. And good relative indicators of stability are the requirement for conventional ventilation only, a low peak in respiratory pressure, and a FiO2 requirement less than 50%. Regarding outcome and long-term survival, overall survival of live-born infants with congenital diaphragmatic hernia is around 71%. And relative predictors of poor prognosis include associated major anomaly, symptoms before 24 hours of age, severe pulmonary hypoplasia, herniation to the contralateral lung, and the need for ECMO. And the size of the defect appears to be the strongest predictor of mortality. Pulmonary problems continue to be a source of morbidity for long-term survivors of congenital diaphragmatic hernia. And children receiving congenital diaphragmatic hernia repair who were studied for 6 to 11 years of age demonstrates significant decrease in forced expiratory flow at 50% of vital capacity and a decreased peak expiratory flow. Both obstructive and restrictive obstructive lung disease can be seen. And those without severe pulmonary hypertension and barotrauma do the best. Gastroesophageal reflux disease, which is reported in more than 50% of children with congenital diaphragmatic hernia, and gastroesophageal reflux disease is more common in children whose diaphragmatic defect involves the esophageal hiatus. And intestinal obstruction is also reported in up to 20% of children, and they might result from a midgut volvulus adhesions or recurrent hernia that becomes incarcerated. Recurrent diaphragmatic hernia is reported in 5 to 20% in most cases, and children with patchy repair are at highest risk. Children with congenital diaphragmatic hernia typically have delayed growth in the first 2 years of life, and the contributing factors for this delayed growth include poor intake, gastroesophageal reflux disease, and a calorie requirement that might be higher because of energy required to breathe. And many children normalize and catch up in growth by the time they are 2 years old. Neurocognitive defects, majority mild to moderate, are common, and they might result from the disease or the interventions. Serious hearing loss might also occur in up to 28% of children who underwent ECMO. And other long-term problems include pectus excavatum and scoliosis. This is all about what I have regarding congenital diaphragmatic hernia. Thank you for watching.